introduce Tim Olson to kick us off. And my name is Candace Maskey, and I'm also with the Olson Group.
Okay, so I'm going to just start with a little bit of history. This is Tim Olson with the Olson Group. We also have Daryl Hunter from Pareto Health Coalition. We're going to have Daryl do a few of the slides. Cindy Rush is on the call as well. And Cindy was from the very beginning of our Pareto Health program. And at the end of this, you can type in questions. And we thought it'd be great to have Cindy on the call, that if any of you'd like to ask a question of Cindy, her experience over the last 6 years, we thought it'd be very helpful. And I thought I'd start by just talking a little bit about Sunflower. As you all know, Heather Fuller is the executive director. The Olson Group has been the consultant for Sunflower the last 16 years. And way back in 2002, 2003, Blue Cross was our health insurance provider. It was a fully insured plan. And about every 2 to 3 years, there were 6 or 7 hospitals with Sunflower that participated. And every 2 to 3 years, we would go to the market. And we had Blue Cross for 2 to 3 years. Back then it was PHS, Preferred Health Services. We had them for a couple of years. Then we went back to Blue Cross. Then it was Coventry, then Blue Cross again. And if you're fully insured at your hospital, you probably know that that's kind of what we do is in market evaluations. Well, Cindy probably remembers this, and Heather, but we got a 59% increase from Blue Cross. And that's when the hospitals got together and we said, we need to figure out how we can take control of our healthcare spend. And as you saw by the announcement, really drive domestic utilization. How can we get our employees and dependents coming to our own hospital? And then if our services aren't provided, then how can we maximize our discounts when we go somewhere else? And so that's kind of how the Pareto Health program got started. I'm going to take 30 seconds to tell you about the Olson Group. We have 28 employees on staff, all dedicated to benefits. I have a business risk partner, Ellerbrock Norris, ENI. They have 45 employees. So we have over 70 employees, dedicated benefit professionals that really address risk. We have 55 critical access hospitals as customers. We have over 100 healthcare customers and about 150 total customers, and we have 5 offices. So just to give you a little bit of history about us. The Pareto Health program now is in its 6th year, and I'm going to be turning this over to Daryl Hunter to give you how the structure of the plan is. The hospitals enjoyed a $1.5 million distribution in 2017 that was given here in 2018. And now we have 15 hospitals that do participate in the program. We have over 3,500 covered lives in the plan. And we're looking at another positive distribution this year so far, how the program's been running. So that just gives you a little bit of history. And I do have, we have a slide up here called BUCA. If you're not familiar with what BUCA means, in our industry, at all the circles that I work with all my colleagues in the benefits world, BUCA is a very common term. It is Blue Cross, United, Cigna, Aetna, and Humana. Those are the big key players around the country. You all remember Obamacare came in 2010, and there are winners with Obamacare, and the big winners are the BUCAs. And the reason they're the big winners is because of the medical loss ratio that is the law with Obamacare. They have to spend 80% of every claims dollar, otherwise they have to write a check back to you. And so they're incentivized to always meet that 80% claims expense rule. And as a result, most of the stock prices have gone up well over 250%. So that chart tells a very compelling story on how the insurance companies are really winning. Our next slide is the confidential agreements, I think, with the BUCAs. If you think about an insurance company like Blue Cross or United or Aetna, they have a confidential agreement with you as a healthcare provider. They have one with the pharmacies, with the pharmacy benefit managers. They have one with urgent care centers, outpatient. And those are confidential between the insurance carrier and the provider. So us as consumers, we're not privy to any of that information. And so when we get to the financial risk spectrum, which is the next slide, I'm going to use, if you're fully insured right now, that's over on the far left. I've got 28 employees on my plan, and I got a 27% increase for Blue Cross Nebraska this year. And I'm really limited to the strategies that I can do with my fully insured plan. I can increase deductibles, transfer risk to the employees. I'm sure all of you are familiar with that if you have a fully insured arrangement. And so we wanted to get away from not having any control, and that was really the common theme 6 years ago in kicking this off. And when you go over to, there's fully insured with HRA, so I can do a deductible buy down. That's been around for, the 39 years I've been doing this. They have level funded dividend eligible plans. But when you get into the self-funding and the coalition, that's when you're really starting to move the needle and bend that healthcare spend trend and take control. And that's what we're going to have Daryl talk about on this solution. I told Heather that we're going to have a couple of seminars, 2 or 3, because there are other solutions that we work with hospitals. The Pareto Health Coalition is a successful solution. And so this is the one we wanted to kick off this series with. And so at this point, I'm going to turn this over to Daryl. And Daryl Hunter is with Pareto. They office out of Philadelphia. I told you about our numbers with our hospital coalition arrangement, but Pareto has over 700 employers that are in these types of plans in all different industries. And with that, Daryl, I'm just going to turn it over to you and go through the structure of Pareto Health and your philosophy and so forth.
Perfect. Thank you, Tim. Thanks, guys, for taking the time to learn more about our program and the Olson Group. As Tim mentioned, I'm Daryl Hunter with Pareto out of Philadelphia. At Pareto, we structure and manage employee benefit group health programs. That's our day-to-day. That's what we're passionate about. But our programs are actually owned and controlled by the employers that are a part of that program. So if you were to join our program, you would become a part owner with those other 15 hospitals. Since you guys all have hospitals to run, the day-to-day responsibility of running those programs falls on us. That's our expertise. You guys run the hospitals, we'll run the group health program. We are independent of the major players, those BUCAs that Tim talked about. And so we are able to truly look out for the best interest of those hospitals. We're in the business of trying to save our clients money. We're not in the business of trying to make money for our shareholders. Our goals for our employers are really twofold. We want to give you guys what we believe is that best, most robust mousetrap to fund your claims that need to be funded, those large claims. And then let's focus on actually reducing your cost of healthcare. As Tim mentioned, let's drive that domestic utilization. Let's get the most out of the discounts we can get for those procedures that can't be done in-house for you guys. And the easiest way we're able to get employers to do that is to take the long-term view. The healthcare industry has everybody trained to look at 1-year increments, right? Your fully insured policy, your stop-loss policy, everything is on that 1-year increment. But you guys have made an agreement to pay for the healthcare spend of everybody that works for you for as long as they work there. And so let's look at the healthcare cost as that long-term liability. What can we do to reduce that 10-year cost? And then we're also able to use our size and scale, as Tim mentioned, to increase the value that we can provide, especially in terms of cost containment vendors and things like that, to our clients. Our quick stats, we currently have around 725 members throughout the country. That's around 90,000 enrolled employees, 200,000 belly buttons is the technical insurance term for enrolled lives. The bottom two numbers are things we're really proud of. The total trend average, that's the admin fee, that's their insurance premium, that's the money they spend on small claims, all that combined is trending at 3% a year. And a big chunk of that is due to the fact that we have high quality broker and consultant partners that we work with, like the Olson Group. They really drive that for their clients. And then that bottom number is our renewal ratio. We don't lock groups in. Our program is set up so that if you want to leave, you can leave. You have run-out protection if you decide to leave. But groups have really bought in, they've seen the results, and they've stuck around. This is our ability to drag stars around in Adobe Photoshop, but it is the location of where all of our groups are for Pareto. For those of you that are fully insured right now, the product it's simple, it's easy, it makes sense, right? You pay your known premium and you don't have to worry about it until renewal rolls around. The downside is that it's filled with the carrier profits we talked about. It's got a higher tax load than is associated if you move to a self-funded type of platform. And most importantly, you get no control and you get no data. Maybe you can mess around with the HRAs, but you don't really have the ability to figure out what's going on with your plan and make the changes needed to try and control those costs. The back of the envelope fully insured renewal model shows you that you're basically paying for your small claims yourself at the moment anyway. They're charging you a fee for your admin, your taxes, and your profit. They're charging you a fee to cover your large claims, and then they're looking at how your small claims ran, and that's how they determine what your increase is for the next year. And so you're already, in effect, paying for those claims. And so that leads groups to try and self-insure. Why would you do that? Reduce cost. We're pulling out those admins, the taxes, the carrier profit. You're now no longer pre-funding the claim, so the cash flow is improved. But most importantly, you are getting the control and the data you need to make those informed decisions. The question then is, why isn't everybody self-insured? And the reason behind that is that it's not a pooled product. And so those of you that are self-insured, maybe you have experienced a laser or a large premium increase. And one of the biggest benefits to our program is that we're able to take those large claims and we're able to pool them. And so we can do things like never issue a new laser at renewal. And so those of you that are fully insured, that may be a confusing term, but I'm sure the Olson Group will be happy to explain those to you after this call. Big picture, the large claims cost for a single employer are volatile. When you're self-funded on your own, or in general, you're going to have good years with your large claims, and you're going to have bad years with your large claims. It's bumpy, it's up and down. What our program does is provide a way to stabilize that. Jump back one slide. Oh, there we go, I got it now. The way our program works is each employer, each of the hospitals, will put basically in a giant bucket all the premium for their large claims. And then we're pooling that, we're sharing that risk throughout everybody. And so if you have a bad year, you're supported by one of your fellow hospitals' good years. And if you have a good year, you support another hospital's bad year. We can accurately predict across all 15 hospitals the large claims for the group, for all 3,000 plus lives. But it's harder for each individual hospital. And so it provides that stability on the large claims. The structure of our program is flexible. Your benefits can be as you design them. You can choose what network you want. You can choose what third-party administrator you want to help you facilitate that. And the big thing here is you can write your plan design to help drive that domestic utilization. If you want your employees to see very little change, they can see very little change. But if you want to rework that plan to drive everything you can in-house, we can help you do that. And more importantly, the Olson Group can help you do that. Our big value proposition is that what we're doing, our health program, is designed to provide a mechanism to reduce that year-to-year volatility and risk associated with being self-funded. We're trying to take that wavy line and we are smoothing it out to give access to self-funded to those medium-sized employers to then allow them to really focus on reducing their cost of healthcare. The first thing we give all of our groups access to is the data. We are as transparent as possible about everything. All of you guys would have access to our data analytics partner to show you where your claim spend is, where it's going in terms of forecasting. You can look to see where people may not be getting proper preventative screenings or may not be properly managing their chronic conditions. All that info flows through this at the level of access you guys are comfortable with. And then we're able to take our size and scale and build in a whole bunch of cost containment tools to help you guys control your costs. So some of the highlights are on the RX side, where we have the ability to offer better contracts in which all the rebates would go back to you guys. With airtight, cleaned up contracts with all the rebates going back to you. And a clinical pharmacist to review those high dollar amount drugs or those drugs where they think that there is an alternative available. We have an ERISA attorney that's in effect on retainer for you guys if you have any questions involving anything to do with the program or your health insurance spend. We've got programs to help find alternatives for people that may be COBRA eligible or maybe Medicare eligible to see if there is a benefit to them in which they can find a different plan besides being on your plan for their health care. We have a program to help support people with cancer diagnoses to make sure that they are getting the treatment they need. If somebody gets a rare, severe type of cancer, let's make sure they're going to the center of excellence that can get it right the first time around by a doctor who sees multiple types of that cancer. And I think most importantly, and one of the hardest things to put an ROI on are our member meetings. We have member meetings in Nashville where we have a board that is run by the hospitals that are in the captive, they're in the program, and they help decide where the program is going to go. We bring in cost containment vendors that help educate you on ways to control your costs. But the biggest part of that is the ability to meet and engage with your peers, to have that conversation of how are you steering people into the hospital? How are you messaging this? How are you messaging that? Did you try this program? Did you try that program? To have that on a peer-to-peer basis, I think is an invaluable part of what we do. To wrap it up, if you go from fully insured to self-funded, you're going to save money, pulling out the taxes and the fees and the carrier profit. If you go from fully insured to a self-funded type of arrangement and you focus on controlling your costs, you're going to save a lot of money over the long haul. And our goal is to help the mid-sized employer have the stability they need to go self-funded and be comfortable focusing on controlling their costs. If this makes sense, if you think this concept resonates, or if you'd like to learn more, I fully encourage you guys to contact the Olson Group to get a little more details on what we're trying to do.
Okay, so are we back on? Okay, this is, can everybody hear me? This is Tim Olson.
Yep.
Okay. So we wanted to have this run about 30 minutes. So there's a couple of, just a couple of thoughts I want to leave with you, and then certainly we want to address any questions that you might have. We had 3 new hospitals join the captive January 1st, 19. And probably the main reason it resonated for them, they were all fully insured, and they're able to now spread any potential high claims down the road over 3,500 lives versus just one group I think had 88, another one had 67, and we had one that was actually had around 55 employees on the plan that joined. So just to confirm what Daryl was saying. Now we have the ability to take a group of 80 or 100 and get the benefits of having the risk spread over 3,500 now that we've seen the Pareto Health Coalition grow, much more so than when Cindy first, was on board with the six critical access hospitals that we kicked it off. The other thing I wanted to have each one of you just ask yourself a question. What have you done with your current program that reduces the size, the frequency, and the severity of claims? Daryl talked about cost containment. Well, cost containment for a bank employee or a manufacturer or a legal firm, it's way different than a healthcare provider. So our strategies that we have with our healthcare providers vary quite a bit. And our risk strategies are deep. We have a toolbox that has a bunch of them. Those are the kinds of things that we would reach out to you if you think you have a fit for something like this, that we would talk to you individually about on how you can really move the needle there. And so we would do that with any of the groups that might have an interest. You can follow up with Heather, or we can reach out with you as well. With that thought, I wanted to open it up for Q&A. You can type in questions. I think we have everybody on. I think we have everybody on speaker as well. I did want to maybe have Cindy comment. Cindy, you've been in the plan for the last 6 years, and maybe you could share a little bit of your thoughts and experience.
Well, we were one of the larger hospitals that actually took part with the CAH group, and we had been partially self-funded in the past before we joined the Sunflower Group, and so it wasn't a new concept to us, and it had been successful for us in the past until Blue Cross came to us and said, oh, we're taking a 39% increase in our premiums on all of the self-funded plans, and we had such a successful year, they had not paid $1. Everything had been internal. It was under our stop loss amount. And so that's when we joined the Sunflower Health Network, and for several years we're fully insured with them. But every time we'd go to renewal and we'd come up with ideas of plan design and what we wanted, it was like, oh, we can't do that. If you have 2 options in your plan choices or 2 plan designs, they can only be so many dollars apart, and you can't do this and you can't do that. And by going with this self-funded group, we could kind of create our own plan design, and we set our hospital up into a 3-tier program so that our smallest deductible and copays are if they do services right here at our facility. And so that was helping drive our own employees back to us. And basically in the budget, we're robbing Peter to pay Paul. It all stays in-house. So that was one of the big things we looked at. It's, we've had some years better than others, but I did some calculations yesterday, and since we started this, our average for the 6 years premium increase has been 6.5%. So I think that shows a pretty successful plan.
Yeah. One of the questions that we got were, who were the 3 new hospitals? One of the hospitals was Henderson Healthcare in Henderson, Nebraska. The other one was Jenny Melhem in Broken Bow, Nebraska, and the other one was Westhold in Atkinson, Nebraska. And in Sunflower, we have Clay County that participates, and we have Lincoln that participates in the program too. Do we have any other questions that people wanted to ask?
I would ask one of Cindy, is the program more work? I think that a lot of people think that joining to something like this would be more work on you and your staff. And so if you have any follow-ups on on that part of it?
Actually, it's not, because we hire BMI to be our third-party administrator. And so everybody thinks they have BMI insurance. They really don't. We tell them that we're self-funded. We try to explain it to them, but in their brain, they still have BMI insurance. And BMI's the bad guy when it, you know, if something isn't within the plan contract and such, you know, they're the ones that visits with the employees and does all the bad guy work. So no, actually on our part, it's not any harder than any other type of design.
Very good. We had a question on how does the multi-tier co-insurance and deductible work? And excellent question. What we've done with all our groups is we add a tier that we call a domestic tier. That's for your own hospital. And so we reduce the deductible, we reduce the out-of-pocket to encourage employees to come to your facility. That would be tier 1 as we normally call it. And then tier 2 would be the network that you choose. And then tier 3 would be out of network.
We do have another question that just came in. What are the most common provider networks used?
It depends what location that you're at. The most common networks that we use are Blue Cross, Providers, First Health, and Midlands Choice in the region. But those things we can also help individual hospitals with and talk about network, plan design, risk strategies, how you're going to move the needle, how can we increase domestic utilization. We would do that individually on site and help, because every plan's a little bit different. That's really the beauty of working in this arena, because everybody looks at it a little bit differently. Everybody has a little bit different view on what strategies fit them. And so that's something that we would discuss with your executive team in designing it. Did we have anything else, Candace?
I do not have any other questions.
Heather, I want to thank you for, appreciate you and helping put this together. Thank you for the hospitals in participating. Thanks, Cindy, for your comments. And we are going to be sending out, we have a book that's been written by me and another person on our staff and my consortium on breaking the status quo. And it has a lot of these risk strategies that we talk about. So every person that's been on or every hospital that's been on the call, we're going to send you a complimentary copy of Breaking the Status Quo as a thank you for participating. And with that, we'll conclude the webinar and make it a great day and a great weekend.
Thank you, guys.